Good afternoon to all of you. We'll be starting with bone tumors. Now, about bone tumors, as all pathologists, when we get a sample of bone tumor, it is not totally restricted to what we see under microscopy. It has to be clinically correlated with patient's symptom, sight, and radiological features that we see. It's the summation of all that we arrive at a particular diagnosis of a particular bone tumor. Sitting only with the microscopic slide and diagnosing bone tumor would be evidently wrong. So, clinical correlation in case of bone tumors is very, very important. Now, the first questions when we receive a bone tumor that we often ask is which all bones are affected, which part of the bone is affected, what is the age of the patient, and what are clinical features and X-ray findings. Now, before we start with bone tumors, you need to know something about the predisposing factors. Why does bone tumor happen in a particular person? Yes, there is some predisposing factors are previous bone infarcts, history of chronic osteomyelitis, history of Paget's disease, history of overt exposure to radiation, if they are wearing a metal processors for long duration, and which is not evident is they have inherent mutations in P53 and RB. Now, something that we decide before looking even at the slide is what is the duration of the lesion or what is the symptom they are coming with. If they are basically asymptomatic, then most probably would be a benign lesion. If it's a slow growing mass over years, then most probably it's a benign lesion. But if the patient comes with pathological fracture, there is a high tendency that we might be dealing with a malignancy. But benign tumors also do present with pathological fracture for the first time. Now, to name some bone tumors, if I tell you to remember or tell me some bone tumors you know of, the first thing that would ever pop up from your mind would be an osteosarcoma, which you must have heard it somewhere in your books. Or it can be Ewing's tumor, or it can be even a lymphoma. So let's look at how do we classify the bone tumors. Now let me tell you, this classification is not new. This is a very simplified version of what is being given in WHO. Pay attention to each word of what I am talking about right now. The classification of the bone tumor is way far more complicated than what is being shown right now to you. Now, this is a very simplified version and the percentages of the lesion have changed over time. Now, among all the bone tumors, most common tumors are those which are arising from hematopoietic elements. Example would be a multiple myeloma. I hope by this time you know what multiple myeloma is. Multiple myeloma is a plasma cell disorder. Okay, so the most common bone disorder would be a hematopoietic arising from hematopoietic elements, that's multiple myeloma. Then comes you have osteogenic ones, that is then you have osteogenic, that has been divided into benign and malignant. Now benign ones are osteoblastoma, osteoblastoma, and the malignant all-time favorite osteosarcoma. Now something I need to tell you in front is that osteosarcoma is one of the primary bone tumors. Primary bone tumor that you see. Hematopoietic tumors arising from bone. The tumors which are most common in bone is hematopoietic. But the primary bone tumor most common is osteosarcoma. I hope you can make out the difference. Which is arising from the bone would be osteosarcoma, which is most commonly seen would be from the hematopoietic element arising from the bone is osteosarcoma. Then let's look at the chondrogenic one. The benign ones are osteochondroma, chondroma, chondroblastoma, chondromyxoid fibroma. Whereas the malignant one would be chondrosarcoma, which has been further divided into the conventional variety, the dedifferentiated, mesenchymal, okay, Next comes unknown origin. We don't know where it is arising from. It might be the histiocytic area, that is from the histiocytes, or it can be from the osteoclast. So they actually don't know where these tumors are arising from. Benign would be giant cell tumor and malignant would be Ewing's tumor, adenoadenoma. Then certain would be having a definite origin like histiocytic. So you have benign fibrous histiocytoma and the malignant is malignant fibrohistiocytoma. Similarly, you have lipomas, your neurilemomas, and the notochordal ones, the malignant one called chordoma. When they ask you to write classification of bone tumors, they expect you to write hematopoietic, they expect you to write bone arising from the osteoid, that's osteogenic, chondrogenic, unknown, and then among others you should write about histogenic, fibrogenic, and notochordal. Now let's look at certain tumors have predisposition for certain areas. Like if I ask name tumors arising from epiphysis, your answer should be giant cell tumor bone, chondroblastoma bone. You have osteomyelitis which might arise from the epiphysis, aneurysmal bone cyst, and clear cell chondrosarcoma. Okay, so you have tumors would be chondroblastoma, giant cell tumor, and clear cell chondrosarcoma. Okay, next clear cell sarcomas. Then next would be the ones which are arising from the metaphysis are osteochondroma, osteosarcoma, chondromyxoid fibroma. Okay, so I'll repeat again. The ones which are metaphysis, osteochondroma, osteosarcoma, chondromyxoid fibroma. The ones which are arising from diaphysis are you have Ewing's tumor, you have fibrous dysplasia, you have brown cell tumors like Langhans cell histiocytosis and Ewing's tumor which falls into this. So diaphyseal tumors are Ewing's tumor, Langhans cell histiocytosis, fibrous dysplasia. Then tumors which have predisposition for particular site. Example would be if I think of multiple myeloma, the two sites I will be thinking would be skull bones and vertebra. If I get a lesion in mandible, the thing which I would be thinking would be a would be a cyst or an adamantinoma. If I am getting a lesion in the spine, as I've told you, multiple myeloma, the second would be metastasis. If I am getting a lesion in the humerus, then I am thinking of either a metastasis or enchondroma. If I am getting a lesion in the pelvis, the first thing that comes into my mind would be a chondrosarcoma. If I get a lesion around knee, I have a thought it might be an osteosarcoma. If I am getting a lesion at the tibial shaft, I might be thinking of straightforward an adamantinoma. Okay, and if I get small bone lesion that is in the hands and feet, I would be thinking of enchondroma. Okay, so lesion in the skull and the vertebra, I think of multiple myeloma. In the jawbone, I think of adamantinoma. In the rib, I think of mets and enchondromas. And then if in the pelvis, I think of chondrosarcoma. If around the knee, I think of osteosarcoma. If on the tibial shaft, I think of adamantinoma. And if I get small bones involvement, I think of enchondromas. So let's look at this broad classification as chondrogenic, osteogenic, fibrogenic. What is this genic? It means that the particular tumor is producing osteoid, is producing cartilage, has fibroblastic differentiation. First, among bone forming tumors, benign ones, osteoma, osteoid osteoma, osteoblastoma, and osteosarcoma. Among these lesions, which you most predominantly see would be an osteoma or osteoid osteoma. Then comes the malignant variety, osteosarcoma. Now look at the bone lesion that you see here. Can you see a lesion here? and these are frontal osteomas. Now, what are osteomas? Osteomas are projection from the subperiosteal or endosteal surface of cortex. Basically, think of a lesion that's arising or uplifting just the cortex of the bone. Most commonly seen in the skull and facial bones. What do they do basically? They basically cause just a bit of facial disfigurement. Usually seen in middle-aged, usually tend to be seen solitary. If multiple, then we think of Gardner's syndrome. Now, if you have to go back to Gardner's syndrome, what would you find? You'll find lesions in the colon, right? Next, what will happen to them? What is going to happen to these? Basically, as they are benign tumors, there's nothing much of a clinical significance. They produce a bit of a facial deformity. If they cause too much of trouble, they are excised. What are you going to see? I told you, basically a cortical lesion which contains only the bone. So you will see the trabeculae, normal trabeculae of bone with, this is the normal trabeculae of the bone, and then in between you have these connective tissue spaces which contain blood vessel. Now, be it osteoblastoma, be it osteoblastoma, these two lesions are having a very similar morphology. That's under microscope. We decide on the basis of clinical significance, the site of lesion and the size of lesion, that what we are dealing with. Otherwise, under the microscope, osteoblastoma, osteoblastoma looks almost the same. Now, what is osteoblastoma? Osteoblastoma is usually less than 2 centimeter, usually seen in teenage. It's usually seen at the appendicular skeleton, at the cortex of the bone, cortical lesions, okay, cortex of the bone. It's pretty painful lesion because the osteoblasts that are there in that lesion tend to produce prostaglandin E2, and this prostaglandin E2 tends to elicit a lot of pain, which gets relieved by aspirin. Now, as this is a cortical lesion, it tends to cause a cortical area. There might be a reactive bone surrounding that. So, you have a central nidus, that is a central area which is lucent, that is dark in color, with a reactive bone surrounding that. Whereas osteoblastoma on the reverse is more than 2 centimeter, involves the spine. One is at the appendicular skeleton's hand and feet, whereas osteoblastoma is seen in the spine. One is at the cortical lesion, whereas osteoblastoma is medulla. That is why X-rays become a very important feature in diagnosing bone tumors. You need to speak to your radiologist and orthopedician before you sign out a report of a bone tumor. Then, in osteoblastoma, pain is dull, it's achy, and it does not get relieved by aspirin. And something in X-ray, you don't have a reactive bone formation. Okay, so osteoblastoma and osteoblastoma, both of them have similar microscopy. In case of osteoblastoma, think of a lesion that's coming in my hand, that is cortical with a reactive bone formation and less than 2 centimeter, which is very painful. Whereas osteoblastoma is more than 2 centimeter, comes in the spine, involves the medulla, does not get relieved by aspirin, and there is no reactive bone formation. Now, that is seen at the appendicular skeleton. So, this would be less, if this is less than 2 centimeter, I would rather call it as osteoblastoma. Now, can you see a central nidus here? And this is the reactive bone. Now, this is the microscopy. You have reactive bone here. You have this bone, intervening trabecular bone, and you can see this osteoblast roaming around that, and some connective tissue, basically all benign. So, from the benign lesion, we move on to a malignant lesion. Let's look at the case scenario. A 17-year-old girl presented in the casualty with fracture of left thigh bone. A 17-year-old girl with fracture, that is a pathological fracture, because that age the bones are quite stable. She gives history of painful and progressively enlarging mass just above the left knee since last 2 months. 2 months is a short duration over that pathological fracture. So you should be at a younger age, think of a malignant lesion. So this is the picture. You can see here it's a huge tumor. So the first diagnosis that should come up would be an osteosarcoma. Now osteosarcoma, as I've already emphasized, is one of the most common primary malignant bone tumors. Now it has a bimodal age of presentation. Bimodal is it's seen in early 20s or in teenage and then in elder age group. Now what are the predisposing? That is why it's been divided into primary osteosarcoma and secondary osteosarcoma. Now primary osteosarcoma tends to arise per se without any predisposing factor, whereas secondary osteosarcomas tend to have predisposing factors like Page's disease, bone infarcts, prior radiation to some any other lesion. Now as I told you, osteosarcomas tend to arise from metaphysis. Put this in your mind, osteosarcomas arises from metaphysis. Now why do they predispose to metaphysis is, they say that that's the area where the maximum bone activity or growth takes place, and that is where the maximum proliferation takes place. So wherever is maximum proliferation, there is more tendency of developing a carcinoma there. The most common site would be in and around joints, as I've shown you in the clinical case scenario. Next comes the classification. It has been classified as primary or secondary. I've already emphasized primary is the one which comes per se without any predisposing factor, whereas secondary is the one which we see in elder age people. The site of origin I've already told you. Then multicentricity. There are tendencies that osteosarcoma can be multiple, okay, and on the basis of histology. That is, I will come to that point at the later. Now, in osteosarcomas, you need to remember that there is suppression of p53 and RB and upregulation of cell cycle regulators like MDM2, and which causes further suppression of p53, causing development of osteosarcoma. So you have mutations of p53, RB and INK4 for development of osteosarcoma, along with upregulation of cell cycle regulators, that is MDM2. Now these MDM2, these cell cycle suppressors or regulators are actually used for detecting low grade osteosarcoma. So if you have an osteosarcoma which looks low grade, you can do an immunohistochemistry on that tumor by doing MDM2, and that would be positive in a low grade osteosarcoma. Now something characteristic. Now as in New Robbins, when we were taught, for us these features were deep epignomonic lesions that you see in osteosarcoma, but the latest Robbins says that these are just a supportive evidence. They are actually not pathognomonic of osteosarcoma. The X-ray features are, you have sun ray appearance or sunburst appearance. You can see that the cortex, these lines are coming as if like sun rays or sunburst appearance. This is the whole tumor, and you have this lines coming, sun ray or sunburst. You can see here also there's a tumor and this sun ray and sunburst appearance. Then, as this is a tumor that's arising from metaphysis, it tends to raise the bone, it tends to raise the cortex. So there is an angle that is formed by raising of the periosteum, and that's called Codman's triangle. Now Codman's triangle, when we were taught as undergraduates, was pathognomonic of osteosarcoma, but over the years we got to know that any aggressive tumor can actually cause a Codman's triangle. It's basically the elevation of the cortex that is caused by the growing tumor. So Codman's triangle is one of the pointers saying that you're dealing with an aggressive aggressive tumor that might be osteosarcoma. Now that's a triangle that you see near the arrow here. This is the triangle. Okay, so now about the gross. The gross is described as, this is a cut section of the bone showing a irregular grey white gritty lesion with areas of hemorrhage. Let me describe again. It's a cut section of bone showing a grey white gritty lesion which is irregular with areas of hemorrhage. This is another one, a gravite irregular growth pushing the muscles. And what you see here is the microscopy is, it's called osteogenic. So what is it causing? It's laying osteoid, and this osteoid is pink lace like osteoid, and they are surrounded by pleomorphic spindly cells. Why pleomorphic? They have their alteration in shape and size. They are hyperchromatic. Can you see here? Typical lace like chromatin with pleomorphic spindly cells, and that's your osteosarcoma. There are different varieties on the histological variant as chondroblastic, which is seen in younger age group, fibroblastic, where you have fibroblast, telangiectatic, meaning vessels. Okay, this is the vessels that you see around that pleomorphic cells. So with this, I wrap up today's class. Today I dealt with general information about bone tumors and osteoid forming tumors. I don't want to rush on to the thing. I will be finishing it within next class. So today is benign tumors, classification of tumors, and then I dealt with osteoid tumors. Now important thing for university is 1. Classification of bone tumors. 2. Osteosarcoma, both gross, microscopy, clinical feature and radiological finding. 2 marks question or a half marks question would be enumerate bone forming tumors. I want you at the end of the class, within 5 minutes of ending the class, or at least give you 10 minutes of ending the class, you're supposed to send the notes of classification of bone tumor from your book, from your textbook, and draw the microscopy of osteosarcoma. That is all you need to send. I will repeat again. All of you need to send me first the classification of bone tumors that you copy down from your book, and the microscopic feature or microscopic diagram of osteosarcoma. Thank you all.